So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's get paid.
I am Nick Servati. I am a cardiac ICU pharmacist at UMass and program director there for the cardiology program. And while Lance took us below the bundle, I'm going to take us above. We're going to be talking about adenosine versus calcium channel blockers for the use in SVT today. I have nothing to disclose for this presentation. We're going to go through some current guideline recommendations for the treatment of paroxysmal SVT, recognize why we have other options than adenosine out there as our first-line pharmacologic therapy, go through some of the current available evidence for calcium channel blockers, and then discuss scenarios when maybe not to use either agent. So, really SVT is an umbrella term. It quite literally translates to above the ventricles, and it refers to any arrhythmia that originates above the bundle of His. I think it's often synonymous with AVNRT or atrioventricular nodal reentrant tachycardia, which accounts for about more than 60% of SVTs in the general population. But technically, it encompasses a whole host of arrhythmias, AVNRT, as well as AV reentry tachycardia, such as the well-known Wolff-Parkinson's-White syndrome, where we have an accessory pathway outside of the AV node that's present. Can also include AFib, aflutter, and multifocal atrial tachycardia. But for the rest of today, I want you to kind of think of SVT as being intended as AVNRT. It's a common arrhythmia with a prevalence of about 3 per 1,000 adults and an annual incidence of 36 per 100,000 people. And it does have female predominance, twice as likely to develop compared to males. And it's the most common cause of symptomatic palpitations in patients with no structural heart disease. I think going through the full patho of all of our kind of SVTs is probably beyond today. But AV nodal tissue is really made of kind of a slow and a fast pathway, with the fast actually having this longer refractory period, or that recovery period where impulses can't pass through. So in some situation where you have a premature beat and it hits that AV node during that longer refractory period of the slow pathway, of the fast pathway, it's going to conduct down the slow pathway. And by the time it reaches where they meet back up together, the fast pathway is likely recovered, and what you can end up having is an impulse that's sent back up through the AV node, circling around and around and around in this reentrant beat, sending impulses down, what is the normal ventricular conduction. And so that's the key there. When you have that normal ventricular conduction, you have a narrow complex. Your P waves are usually undetectable. You have almost simultaneous activation of the atria and the ventricles. Your QRS complex should be narrow in most cases, so less than 3 little boxes or kind of 120 milliseconds, because again, these are usually no structural heart disease, and that you have normal ventricular conduction. So our treatment really revolves around disrupting kind of the cycles of refractory pathways that result in this reentry within and around the AV nodal tissue. So real quick, we'll get kind of unstable patients out of the way. For the rest of this talk, we'll focus on stable patients. But for hemodynamically stable patients or unstable patients, between all of the guidelines, the American Cardiology Guidelines, the European Guidelines, and the ACLS Guidelines, they all have a Class 1 recommendation for synchronized cardioversion. Do they give a great definition? No, they don't. It's documented ischemic chest pain. If a patient's altered or showing other signs of shock, that's kind of their definition of unstable. For the patient who is hemodynamically stable, it is the first-line therapy, if possible, is vagal maneuvers. So it's a Class 1 recommendation, and I will say this, between all 3 guidelines across the world, they're all pretty consistent in their recommendations. We know that in 2015, we had the REVERT trial, looked at just over 400 patients in EDs across England, randomized them to the standard Valsalva. Essentially, in this trial, they blew into a tube to kind of meet 40 millimeters of mercury, which we can do in standard practice with just a 10 cc syringe with enough force. They modified that technique, taking the patient from a semi-recumbent position, lifting their legs up and laying them down for another 15 seconds, and then bringing them back up. And what they found was that After that 1 minute, conversion to return to normal sinus rhythm was significantly higher, with the number needed to treat of only 3. And antiarrhythmic use after the vagal maneuver was also lower. Adenosine use was reduced by 28%, and there were 0 serious adverse events. So again, this is a class 1 recommendation because it's simple, it's safe, it's free, and we really should be attempting to do the modified Valsalva. How about stable? After vagal maneuvers, we know that even with that modified technique, success rate was only at 40%, so we usually have to do something else. And the guidelines currently list adenosine as a class 1 recommendation and have since the early 90s. So all 3 giving it a class 1 recommendation. So adenosine, what is adenosine? The way it works is it hyperpolarizes the membrane potential by activating these channels, right? And so we end up having, let me just pull this up here, a decrease in your resting membrane potential. And with that reduction in membrane potential, you get a reduction in action potential duration, and thus the refractory period overall. And in the end, adenosine also reduces action potential duration and the refractory period of atrial tissue surrounding the node. It's common doses for adenosine, usually 6 milligrams, upwards of 12 milligrams for 2 repeated doses, although in certain scenarios we may need higher doses. And in certain considerations for lower doses, so heart transplant recipients who are denervated, if you have central access, you could consider starting off with a lower dose of 3 milligrams, maybe just as effective, and heart transplant patients are generally more sensitive to adenosine. It has an incredibly fast half-life as it gets taken up into those erythrocytes and is metabolized quickly, so we know that that complicates administration and is a challenge with adenosine. So some issues with adenosine. Recent caffeine use, there was a study in 2010 that looked at caffeine, which is a competitive adenosine receptor blocker. Ingestion within 4 hours reduced the odds of termination of your AVNRT. So it was reasonable to dose in that scenario with maybe 12 milligrams to start, escalating dose to 18 milligrams instead of starting off at 6. I think the biggest challenge that we all think about is its administration. We need a healthy adenosine literally reach the heart before it's metabolized. Traditionally, you might push this with a stopcock, kind of have the nurse switch over to the flush, but this isn't foolproof. We know that there can be fumbling, there can be issues. If people aren't doing this often, there's also concerns there. So instead, what you could do is go with a single syringe technique. So kind of draw out the adenosine and normal saline in a 10 to 20 cc syringe. This was studied by some pharmacists and fantastic pharmacists out of Advocate in Chicago, and they ended up finding conversion rates with the single syringe technique were higher at 70% compared to just 40% with standard dosing administration. And all patients in the single syringe arm converted with up to 3 doses, compared to only 70% in the single syringe. I will say there is, some kind of theoretical caution in reactive airway disease. Most of the cases that are out there on this and associating adenosine with bronchospasm are really in adults, particularly at higher doses, the higher doses utilized in stress tests. And apart from some case reports with the standard dosing of adenosine for SVT, the dyspnea is generally short-lived, resolves spontaneously, generally given that short half-life. And if not, treatment options are readily available, whether it's oxygen, inhaled bronchodilators, whether we're throwing some steroids on board, even some case reports of utilizing aminophylline for this. It is extremely rare to have severe adverse events with this in regards to bronchospasm. Most of the other side effects, are usually deemed relatively minor. They're associated with the activation of adenosine receptors throughout other vascular tissue, and so they're mostly associated with kind of vasodilation. So if we think about headaches, facial flushing, nausea, chest tightness, all these things are kind of associated and deemed kind of minor. I don't think all patients feel that way. I think certainly many patients have reported this kind of feeling, this horrific feeling, felt like I was going to die. It was terrible, the worst experience of my life. And I think it has deterred some patients from, coming back and seeking treatment, even if they know what the issue is. Okay, so we have a case. It's a 33-year-old male who presents to the ED. He's complaining of palpitations and shortness of breath since yesterday morning, just shy of 24 hours now. CT reports that he was told he had SVT in the past. He remembers it pretty well. And a 12 lead today shows a regular and narrow complex tachycardia with a rate of 216. Awesome. I'll give it a minute. Looks like you guys are all answering. Looking for assistance, guys, in administration of adenosine after vagal maneuvers were attempted and have failed. What are some things to consider? It looks like most of you guys got this. I agree. All of the above, I think it's reasonable to go through how are those vagal maneuvers performed. Did they attempt that modified Valsalva technique? Does the patient have a history of severe reactive airway disease? Is that something maybe we should tailor therapies away from adenosine if possible? Other past medical history to review. Has there been any therapies that have worked in the past for the patient? Can we repeat prior successes? And obviously, our first decision point is how hemodynamically stable they are. So if adenosine fails, the guidelines recommend that is the point where you could consider an IV calcium channel blocker, specifically diltiazem, verapamil. They give this a Class 2A recommendation across the board. So where does this come from? Well, calcium channel blockers, specifically your non-dihydropyrin agents that are a bit more cardioselective in that regard compared to standard dihydropyridines. You have, let me close that. You have calcium channel blockade, right, working on and inhibiting your L-type calcium channels, and in turn, in your AV nodal action potential, decreasing the conduction velocity and prolonging repolarization within the AV node. Onset, usually within 5 to 6 minutes for both agents, with the duration a little bit longer for verapamil. You'll see kind of two dosing schemes here, and this is from our standard dosing of 2.5 to 5 milligram push dosing for both verapamil and diltiazem, compared to something that came out of a trial in 2009 for longer and slow infusions. Lim and colleagues in 2009 put together a trial looking at slow infusions up to either a max dose or a conversion. We'll talk a little bit about more in a bit. All right. So the most recent update to a Cochrane review was in 2017. They had lost funding along the way from the first iteration of this in 2006, but they had, reviewed basically studies that had patients of any age within 24 hours of onset and had confirmed diagnosis via a 12 lead. They did exclude patients who had SVT induced in the EP lab. And so they took studies there were 8 studies in the original Cochrane review in 2006, but 3 of those actually had and included patients that had induced SVT in the EP lab. So after removing those, they identified 2 new studies and had a total of 7 randomized controlled trials to include that had a direct comparison of any IV calcium channel blocker compared to adenosine at any dose or infusion rate of either. So these are kind of some of the outcomes they were looking at. Major adverse events were defined as a cardiac arrest, prolonged hypotension if a patient had symptomatic bradycardia that ended up requiring treatments, and any kind of acute cardiac failure. But looking at their primary outcome of reversion to sinus rhythm, all 7 studies that they included reported on this, a total of 600 patients. And conversion rates were similar between the 2 groups at about 90% compared to 93%. Confidence interval there crossing 1, and relatively no difference in efficacy between the 2 agents. In terms of major adverse events where this was reported, which is only in 3 studies, it's only 306 patients total for this meta-analysis, the reported hypotension within 2 hours post-infusion only occurred in 1 patient with calcium channel blockers. And again, the authors did comments, obviously this is a low quality of evidence between the 3 studies that were reported. And I will say that 2 of the 3 trials that reported had specifically excluded patients with a systolic of less than 90 at enrollment. I think we would probably deem those patients as hemodynamically unstable, although we don't have a set definition of that. But they were excluded, and so they chose, in that regard, patients that may have tolerated the calcium channel blockers better than expected. For the secondary outcomes, unfortunately, none of the trials reported on length of stay, or importantly, I think, patient satisfaction. So kind of going through and making a tailored therapy for the patients, that just was not included. For terms of rate of relapse within 2 hours, 4 studies reported on this, over 350 patients included, Again, no significant difference between the two. Rate of relapse a little bit higher with adenosine numerically, and this was kind of a theoretical benefit that we may have thought we'd see with calcium channel blockers given the longer duration of action compared to the very quick half-life and metabolism of adenosine, but didn't seem to entirely play out. Overall, for your minor side effects and what was reported, if we look at chest tightness as a commonly reported side effect, in just over 11% of patients in the adenosine group, no reports in the calcium channel blocker group. As expected, one study did report flushing events, and more than half of the patients that received adenosine reported flushing, while none of the calcium channel blocker patients did. So Lim and colleagues, this was one of the 2 new studies that was included in that Cochrane review. They looked at slow infusion of calcium channel blockers and a hopeful means to mitigate any risk of developing prolonged hypotension after infusion. So they prospectively randomized patients to either adenosine in your standard dosing, not in a single syringe fashion, so just 6 milligrams followed by a 10 cc push, repeating with up to 12. And then calcium channel blockers, they included both verapamil and diltiazem, with the rates being the 1 milligram per minute, going all the way up to 20 milligrams for verapamil or stopping if the patient converted, and 2.5 milligrams a minute for diltiazem up to a max of 50 milligrams. If the SVT had not converted by the end of the infusion, patients were crossed over to the opposite group. And I will say in the Cochrane review that looked at these overall results, they did not count the results after crossover, but instead only counted them as initial treatment failure. And so they had a success rate of 98% with either of the calcium channel blockers and around 87% with adenosine. This was statistically significant. The dose to convert more than three-fourths of the patients was around 18 milligrams of diltiazem, which if we think about the standard dosing for a 70-kilo patient, it's about 0.25 mg per kg. So it works out pretty nicely in that fashion. As expected, though, the time to conversion was a bit longer with calcium channel blockers compared to adenosine, working pretty quickly and taking about 6 minutes for either calcium channel blocker to take effect. If we look at baseline systolic blood pressure before the slow infusion and after, we can see here you have definitely the slow infusion mitigated the risk of developing severe hypotension overall, which the authors defined as a systolic of 90 or lower, only occurring in 1 patient compared to none in the adenosine group. And so it's a potential that if it's possible to utilize slow infusion, it might be reasonable to. And maybe this is an opportunity. I know that we don't have it built into our smart pump, so it's not something that's done regularly, and we're often using just the bolus doses. There was a poster presented, so fair warning, there are limitations aplenty to this. I don't have full results to speak to. This was a poster presented at last year's AHA conference. They prospectively randomized just over 50 patients to either diltiazem in the bolus dosing fashion or adenosine at 6 milligrams at a starting dose, followed by continuous infusion of DILT if there was no conversion. They found a 100% success rate with utilizing diltiazem bolus dosing compared to only 77% with adenosine, which is lower than mostly reported conversion rates for adenosine. They also noted that the mean change in blood pressure was not significantly different, nor was there a significant difference in adverse events. But given that this was a poster, and I don't have full results to kind of tell you what those changes in blood pressures or adverse events were kind of defined as. I think in terms of calcium channel blockers and when to avoid, it's pretty crucial to avoid this in patients with left ventricular dysfunction or reduced ejection fraction. Patients who you think are shocky, we obviously should be considering if they're hemodynamically stable or not, and likely should be cardioverted. And if they have other signs of shock to be considering. If a patient presents already taking, pretty decent doses of a beta blocker or other calcium channel blockers and AV nodal agents, it might be a consideration to avoid calcium channel blockers and lend you towards the adenosine track. I think with adenosine, we could argue back and forth about the risk of utilizing this in patients with reactive airway disease, considering higher doses in patients with recent caffeine use if you are going to utilize adenosine, and maybe just considering the patient's prior history. Have they had, concerns and have had terrible times with adenosine in the past? It might be a reason to consider that and tailor therapy for kind of patient's preference. avoiding these in pre-excited AFib, right, where you have that accessory pathway that if you block and inhibit the AV node, you kind of make that accessory pathway the main pathway and can precipitate ventricular arrhythmias in that regard with either agent. Something maybe on the horizon, a trypamil or an intranasal calcium channel blocker. So this is a novel non-dihydropyridine that's being designed really to be self-administered and also short-acting with hopes to reduce that risk of prolonged hypotension after the fact. So far, they've just had a phase 2 trial they published in 2018, so maybe this is something to come, and I'm sure with it will be a significant cost. Time to conversion was relatively quick, and the drop in blood pressure that they noted was really only seen with the highest dose. So we'll see where that goes. They're actively enrolling in phase 3 trials currently. So back to the case. You guys are inquiring what happened. Why did you take so long to come in? You knew that this has happened before, and the patient kind of tells you that they were afraid to come in, and that they had a terrible experience last time. Realizing that this was adenosine, you're kind of going through the vitals. Patient looks hemodynamically stable, and so you're discovering he's also has a history of asthma, and he's been continuously taking his albuterol inhaler for the last 24 hours, likely due to the SVT. But might be a point of concern. So which therapy would you guys use? Would you guys go right to cardioversion? Are you giving adenosine? How are you giving adenosine? All right, I'm going to keep going and the poll. Share those results. Yeah, I think, I don't know if I would necessarily go directly to cardioversion. Looks like some of you selected that. I think this patient's pretty stable at this point. They've only failed vagal maneuvers at this point, so, maybe trying either agent is reasonable. I'd say if I were to select adenosine in this case, I'm definitely going to go for that single syringe, and with the possibility of that being a more effective administrative strategy. And then, I think in this case, maybe given his severe reactive airway disease in the past, his horrible experience with adenosine that kind of delayed him coming in for care, I think I agree with the most of you, about 70% of you put diltiazem, and I think honestly either dose is a reasonable option. If you had the ability to do the slow infusion, great. If you can wait for that to be made and mixed up, but otherwise I think the initial bolus dose of 0.25 milligrams per kilo lines up with the average dose that the slow infusion needed in most patients in the LIM trial, so reasonable to go there. So what are some reasons to avoid calcium channel blockers? I'm going to keep going just to try to keep everyone on time. So it looks like overall, most of you put either presenting on or already receiving other AV nodal blocking agents, or patients with a reduced EF and poor LV function. And I totally agree. I think either of those choices are reasonable and what we should be going with. So some take-home points. Guideline recommendations still maintain adenosine as first line. I think that there is room for diltiazem and verapamil to fit in there. They seemingly are equally efficacious. If utilized at correct doses and maybe even utilizing the slow infusion, it's unlikely to cause hypotension, really associated with far fewer of those minor adverse events, although they may not be so minor to the patient. And so the devil's in the details. Finding the perfect patient and identifying and tailoring the therapy to them is key.
Hey, we thank you, Nick, for coming on.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.